Hi, I'm Cheska Janosa Baldan and I will discuss about the secondary immunodeficiencies. My topic will be focused about the HIV and AIDS. I hope you enjoy the video. Thank you! The immune system is composed of a variety of cells, especially white blood cells and proteins, for which one of the principal functions is microbial defense. A deficit in the immune system can therefore lead to unusually severe or uncommon recurrent infections. Immune deficiency may be primary or secondary. The secondary immune deficiencies or acquired deficiencies are more frequent than primary immune deficiencies. Secondary immune deficiencies are problems of the immune system that are not genetic and which are caused by external factors. An example of secondary immune deficiency is acquired immunodeficiency syndrome or AIDS. The most well-known example of secondary immune deficiency is the immunodeficiency caused by the human immunodeficiency virus or HIV. HIV attacks certain cells of the immune system and prevents them from carrying out their proper functions against microbes. When the immune system is sufficiently weakened, infected people catch atypical and severe infections. This is then called the acquired immunodeficiency syndrome or AIDS. AIDS at this time is often treated by a specialized multidisciplinary team. Immunodeficiency is also the hallmark of acquired immunodeficiency syndrome caused by the human immunodeficiency virus. HIV directly infects a small number of T helper cells and also impairs other immune system responses indirectly. Secondary immunodeficiency disorders can occur, for example, in malnutrition, aging, many types of cancer such as leukemia, lymphoma, multiple myeloma, and certain chronic infections such as acquired immunodeficiency syndrome. A person who is undergoing immunosuppression or whose immune system is weak for other reasons, for example chemotherapy, HIV, and lupus, is said to be immunocompromised. A person who has an immunodeficiency of any kind is said to be immunocompromised. An immunocompromised person may be particularly vulnerable to opportunistic infections, in addition to normal infections that could affect everyone. Distinction between primary versus secondary immunodeficiencies are based on respectively whether the cause originates in the immune system itself or is in turn due to insufficiency of a supporting component of it or an external decreasing factor of it. Secondary immunodeficiency are more common than primary immunodeficiencies and are the result of the primary illness such as HIV or other external factors such as malnutrition or some drug regimens. Most secondary immunodeficiencies can be resolved by treating the primary condition. Etiology. Secondary immunodeficiency refers to an acquired immunodeficiency secondary to an extrinsic cause. The etiology of secondary immunodeficiency is often multifactorial and may present with diverse opportunistic infections. Secondary immunodeficiency is common, and the most common etiology worldwide is malnutrition. Causes of secondary immunodeficiency can be loosely defined by etiology into disorders of general health, barrier integrity, relating to underlying diseases, or as iatrogenic. Severe presentations of common infections and certain characteristic opportunistic infections should raise the suspicion of secondary immunodeficiency. Many secondary immunodeficiencies relate to the use of medications, particularly the new generation of biological agents. Infections, as well as being a result of immunodeficiency, may also cause secondary immunodeficiency. The treatment of the secondary immunodeficiency is complicated and dependent on both the presentation and the etiology of the immunodeficiency. So these are the causes of secondary immunodeficiency with different categories. Endocrine, diabetes mellitus, gastrointestinal, hepatic insufficiency, hepatitis, intestinal lymphangiectasia, protein-losing enteropathy, hematologic, aplastic anemia, cancer such as chronic lymphocytic leukemia, multiple myeloma, Hodgkin lymphoma, graft versus host disease, sickle cell disease, splenectomy. Iatrogenic, certain drugs such as chemotherapeutic drugs, immunosuppressants, corticosteroids, radiation therapy, splenectomy. Infectious, viral infections such as cytomegalovirus, Epstein-Barr virus, HIV, measles virus, varicella zoster virus. Bacterial infections, rare bacterial infections with super antigens that can activate large numbers of T cells, resulting in massive cytokine production, most notably from Staphylococcus aureus. Mycobacterial infections. Nutritional, alcohol use disorder, undernutrition. Physiologic immunodeficiency in infants due to immaturity of the immune system. Pregnancy. Renal, nephrotic syndrome, renal insufficiency, uremia. Rheumatologic, systemic lupus erythematosus. Others, burns, cancers, chromosomal abnormalities such as Down syndrome, congenital asplenia, critical and chronic illness, histiocytosis, sarcoidosis. Secondary immunodeficiency disorders. Systemic disorder, diabetes, HIV infection, malnutrition, immunosuppressive treatments, cytotoxic, chemotherapy, bone marrow transplant, radiation therapy. prolonged serious illness, critically ill, and hospitalized patients. What is HIV? Human immunodeficiency virus is a virus that attacks the body's immune system. If HIV is not treated, it can lead to acquired immunodeficiency syndrome or AIDS. HIV targets and destroys essential components of the human immune system. It belongs to a genus of viruses called lentiviruses, which cause chronic disease in humans and other mammals. If it is left untreated, HIV infection causes progressive and critical damage to the immune system, rendering the host susceptible to potential fatal opportunistic infections and cancers. Now, there are two distinct types of HIV, HIV-1 and HIV-2. HIV-1 is the more commonly associated with AIDS in the US and worldwide. HIV-2 is more rare and typically restricted to areas in Western Africa and Southern Asia. HIV-2 is so uncommon that HIV almost always refers to HIV-1. So now let's discuss the pathophysiology of HIV. HIV first enters the body through the bloodstream. The viral particle is surrounded by a membrane that's studded with viral proteins known as envelope proteins. In this cross-section, the conical-shaped capsid houses the RNA genome. At about 100 nanometers in diameter, HIV is about 100 times smaller than its target cell, which is the T cells. The virus first contacts T cells through interactions between the viral envelope proteins and membrane proteins on the cell surface. Initial binding occurs through CD4 proteins. The binding of the second membrane proteins, called coreceptor, triggers a dramatic change in shape of envelope proteins. The first conformational change allows envelope proteins to insert into the membrane of the T cell. Next, envelope protein pulled back on itself, forcing the fusion of the T cell membrane with the viral membrane. This allows the viral capsid to enter the cell. And inside of the cell, the virus starts to move towards the nucleus using microtubules as a sort of highway system. During this translocation, a viral enzyme known as reverse transcriptase gets to work. Reverse transcriptase has already been primed during its time in the capsid and starts to use cellular pools of DNA nucleotides to make a DNA copy of the RNA genome. As it goes, it degrades a single-stranded RNA. Multiple reverse transcriptase work simultaneously to carry out this task, resulting in a complete double-stranded DNA copy of the viral genome, and meanwhile, the capsid shell begins to break apart. The viral genome has now reached the nucleus. A segment of the viral DNA found by the viral protein integrase starts to make its way across the nuclear pore. Inside the nucleus, integrase binds to cellular DNA, cuts it, and inserts the viral DNA. The viral DNA or provirus can become active immediately or remain dormant for days, weeks, or even years. After activation, the cell begins its transformation into a viral factory. In the first stage, the viral DNA is copied into RNA, a process known as transcription that is carried out by RNA polymerase. For many genes, including proviral genes, RNA polymerase reposes soon after it initiates transcription and requires additional signals from the cell in order to continue. HIV is able to bypass this pause through the recruitment of the protein complex. As viral RNAs are produced, some are spliced that is looped, cupped, and glued back together, producing RNAs of different lengths. The viral RNA transcript contains a short sequence that binds to a protein that attracts cellular proteins that direct the RNA to exit the nucleus through the nuclear pore. Once outside the nucleus, different RNAs have different fates. Some are made into proteins using cellular machinery called ribosomes. Ribosomes read the RNA and produce viral proteins. Other viral RNAs are destined for packaging into new viruses. These RNAs attract gag proteins along their journey to the cell membrane. Along the way, two copies of viral RNA bind together, forming a stable dimerized RNA structure. At the cell membrane, viral proteins including envelope proteins and thousands of copies of gag proteins accumulate and capture the dimerized viral genome. Meanwhile, gag forms a tightly packed goddess that forces the membrane to bulge out. As the viral blood grows, numerous additional proteins are recruited in stages. Near the final stage, proteins known as escort trees appear. These proteins form polymers that actively pull together the membrane of the blood pack, eventually causing the membranes undergo fusion. Once released, the new viral rapidly undergoes a process known as maturation. Maturation is triggered by the dimerization and release of proteins known as protease, which acts as molecular scissors, cutting the gag proteins at specific sites to release shorter proteins, including nucleocaspase proteins that go on to bind and compact the viral RNA, and capsid proteins that form a conical shell around the RNA. The mature viruses are now able to begin a new round of infection with a new host cell, and the cycle begins again. If HIV is not treated appropriately, the person or the patient may have symptoms such as opportunistic infection, oral esophageal thrush, herpes simplex, tuberculosis, pneumocystis, malaise, fatigue, weight loss, fever, and neuropsychiatric effects. Human immunodeficiency virus may lead to acquired immunodeficiency syndrome, or AIDS. Transmission of HIV requires contact with body fluids, specifically blood, semen, vaginal secretions, breast milk, saliva, or exudates from wounds or skin and mucosal lesions that contain free HIV virions or infected cells. Transmission is more likely with the high levels of virions that are typical during primary infection, even when such infections are asymptomatic. Transmission by saliva or droplets produced by coughing or sneezing, although conceivable, is extremely unlikely. HIV is not transmitted by casual non-sexual contact, as may occur at work, home, or school. The following are the different transmission of HIV. First, sexual transmission of HIV. The sexual practices with the highest risk are those that cause mucosal trauma, typically intercourse. Anal receptive intercourse poses the highest risk. Mucous membrane inflammation facilitates HIV transmission. Sexually transmitted diseases such as gonorrhea, chlamydial infection, trichomoniasis, and especially those that cause ulceration such as chancroid, herpes, and syphilis, increase the risk several-fold. Needle and instrument-related transmission. Risk of HIV transmission after skin penetration with a medical instrument contaminated with infected blood is on average about 1/300 without post-exposure antiretroviral prophylaxis. Immediate prophylaxis probably reduces risk to less than 1/1500. Risk appears to be higher if the wound is deep or if blood is inoculated. Risk of transmission from infected healthcare practitioners who take appropriate precaution is unclear but appears minimal. Maternal transmission. HIV can be transmitted from mother to offspring, transplacental, perinatal, or via breast milk. Without treatment, risk of transmission at birth is about 25 to 35%. HIV is excreted in breast milk, and breastfeeding by untreated HIV-infected mothers may transmit HIV to about 10 to 15% of infants who had previously escaped infection. Transmission rates can be reduced dramatically by treating HIV-positive mothers with antiretroviral drugs while they are pregnant, in labor, and breastfeeding. Cesarean delivery and treatment of the infant for several weeks after birth also reduce the risk. Many HIV-positive pregnant women are treated or take prophylactic drugs. The incidence of AIDS in children is decreasing in many countries. Transfusion and transplant-related transmission. Screening of blood donors with tests for both antibody to HIV and HIV RNA has minimized risk of transmission via transfusion. Rarely, HIV has been transmitted via transplantation of organs from HIV seropositive donors. Infection has developed in recipients of kidney, liver, heart, pancreas, bone, and skin, all of which contain blood, but screening for HIV greatly reduces risk of transmission. HIV transmission is possible via artificial insemination using sperm from HIV-positive donors. Vaccines against HIV have been difficult to develop because HIV surface proteins mutate easily, resulting in an enormous diversity of antigenic types. Nonetheless, various vaccines candidates are under study and a few have shown promise in clinical trials. At the present time, there is no effective AIDS vaccine. Prevention of transmission. Effective measures include the following: public education, safe sex practices, counseling for parenteral drug users, confidential testing for HIV infection, counseling for pregnant women, screening of blood and organs, pre-exposure prophylaxis with antiretroviral drugs, Circumcision of men. Universal precautions. Treatment of HIV infection. So what are the stages of HIV? When people with HIV don't get treatment, they typically progress through 3 stages. But HIV medicine can slow or prevent progression of the disease. With the advancements in treatment, progression to stage 3 is less common today than in early days of HIV. Stage 1. Acute HIV infection. People have a large amount of HIV in their blood. They are very contagious. Some people have flu-like symptoms. This is the body's natural response to infection. Some people may not feel sick right away or at all. If you have flu-like symptoms and think you may have been exposed to HIV, seek medical care and ask for a test to diagnose acute infection. Only antigen, antibody test, or nucleic acid test can diagnose acute infection. Stage 2. Chronic HIV infection. This stage is also called asymptomatic HIV infection or clinical latency. HIV is still active but reproduces at very low levels. People may not have any symptoms or get sick during this phase. Without taking HIV medicine, this period may last a decade or longer, but some may progress faster. People can transmit HIV in this phase. At the end of this phase, the amount of HIV in the blood, called viral load, goes up and the CD4 cell count goes down. The person may have symptoms as the virus levels increase in the body and the person moves into stage 3. People who take HIV medicine as prescribed may never move into stage 3. Stage 3. Acquired Immunodeficiency Syndrome or AIDS. The most severe phase of HIV infection. People with AIDS have such badly damaged immune system that they get an increasing number of severe illnesses called opportunistic infections. People receive an AIDS diagnosis when their CD4 cell count drops below 200 cells per millimeter, or if they develop certain opportunistic infections. People with AIDS can have a high viral load and be very infectious. Without treatment, people with AIDS typically survive about 3 years. The following are the clinical manifestations of HIV. Respiratory manifestations: pneumocystis pneumonia, Mycobacterium avium complex, and tuberculosis. For gastrointestinal manifestations, candidiasis and HIV wasting syndrome. For oncologic manifestations, Kaposi sarcoma and AIDS-related lymphomas. For neurologic manifestations, peripheral neuropathy, HIV encephalopathy, Cryptococcus neoformans, progressive multifocal leukoencephalopathy. For depressive manifestations, depression and apathy. For integumentary manifestations, seborrheic dermatitis, atopic dermatitis, herpes zoster, and herpes simplex. For gynecologic manifestations, recurrent vaginal candidiasis, genital ulcers, venereal warts, amenorrhea, and ulcerative STIs. So there are other symptoms of human immunodeficiency virus. Some people have flu-like symptoms within 2 to 4 weeks after infection, called acute HIV infection. So these symptoms may last for a few days or several weeks. Possible symptoms include fever, chills, rash, night sweats, muscle ache, sore throat, fatigue, swollen lymph nodes, and mouth ulcers. Diagnostic examinations. As far as diagnosis goes, there are a few types of HIV tests that can be done, which are antibody test, antibody or antigen test, and RNA or DNA tests. Antibody tests look for antibodies that the bodies made against HIV. Antigen tests look for the virus directly, so antibody-antigen tests detect both antibodies to the virus as well as the virus itself. RNA tests screen for viral RNA, so they also detect the virus directly, and DNA tests look for copies of the viral RNA. Since remember it's a retrovirus, so it copies its genetic material into DNA. For screening purposes, the recommended test is the antibody-antigen test, which is better at identifying early infection. It's also recommended, if the first test is positive, to follow it with a confirmatory test that looks for antibody or nucleic acids. Treatment modalities. Currently, there is no cure for HIV or AIDS. Once you have the infection, your body can get rid of it. However, there are many medications that can control HIV and prevent complications. These medications are called antiretroviral therapy or ART. Everyone diagnosed with HIV should be started on ART, regardless of their stage of infection or complications. ART is usually a combination of 3 or more medications from several different drug classes. This approach has the best chance of lowering the amount of HIV in the blood. There are many ART options that combine 3 HIV medications into one pill, taken once daily. Each class of drug blocks the virus in different ways. Treatment involves combinations of drugs from different classes to account for individual drug resistance, viral genotype, to avoid creating new drug-resistant strains for HIV, maximize suppression of virus in the blood. Antiretroviral therapy general principles. So, antiretroviral therapy aims to reduce the plasma HIV RNA level to undetectable, restore the CD4 count to a normal level. Nursing diagnosis. Imbalanced nutrition, less than body requirements related to altered ability to digest and or metabolize nutrients as evidenced by weight loss. The following are the nursing interventions. Schedule medications between meals if tolerated, and limit fluid intake with meals unless fluid has nutritional value. Provide frequent mouth care, observing secretion precautions. Avoid alcohol-containing mouthwashes. Remove existing noxious environmental stimuli or conditions that aggravate gag reflex. Social isolation related to inadequate personal resources or support systems as evidenced by absence of supportive significant others such as partner, family, acquaintances, or friends. The following are the nursing interventions. Ascertain patient's perception of situation. Spend time talking with patient during and between care activities. Be supportive, allowing for verbalization. Treat the patient with dignity and regard the patient's feelings. Identify support systems available to patient, including presence of and/or relationship with immediate or extended family. Prognosis. The prognosis in patients with untreated HIV infection is poor, with an overall mortality rate of more than 90%. The average time for an infection to death is 8 to 10 years, although individual variability ranges from less than 1 year to long-term non-progression. There is less evidence that treatment of HIV-2 infection slows progression, and certain antiretroviral medications, specifically the non-nucleoside analog reverse transcriptase inhibitors, are not effective against HIV-2. The HIV-1 viral load assays are much less reliable at quantifying HIV-2 if they work at all. HIV-2 viral load assays have been developed, but none has been approved by the U.S. Food and Drug Administration except as blood donor screening tools. Once infection has progressed to AIDS, the survival period is usually less than 2 years in untreated patients. Persons in whom the infection does not progress long-term may not develop AIDS for 15 years or longer, although many still exhibit laboratory evidence of CD4 T cell decline or dysfunction.